sexually abused.
Countertransference is something that psychologists all have to be very cautious of.
Yes.
So as a psychologist, a licensed psychologist, have you ever experienced countertransference from sexually traumatized children or young adults? And if so, how did you deal with it?
I never had countertransference sessions.
Oh, you never?
I'm just kidding. Countertransference is a real tricky one because in many ways, probably the most important one that one has to be aware of is that there's this whole rescue fantasy. I'm going to heal this child. You have to be careful about that. The other pieces that are important is the therapist being a survivor of him or herself. Because if the therapist has not, if the therapist, has their own sexual trauma history, and they're not aware of it, then what they're going to end up doing is this strange dynamic where by rescuing the child, somehow they rescue part of themselves. This is how I deal with it. I have my own therapy to talk about how difficult my patients are, how difficult my psychology students are. That was a joke. No, you have to actually be really aware of that. It's a very important thing because countertransference is also an incredible, source of information if you can tune into it. Here's an interesting one. With sexually abused, children and adolescents, a lot of them are very provocative. They'll trigger, certain things that you may not be aware of. Okay? They may be eroticized countertransferences, but a lot of them are what I call toxic kids. They're so damaged themselves that they actually push adults away. They're triggering anger and responses in kids, or in the therapists or adults who are treating them. They just don't want to have anything to do with it. So the kid sort of protects themselves. They look kind of like they're quote unquote crazy, right? And people just go, they can't be handled, right? So countertransference is very important. The way I pay attention to it is if a kid, triggers some feelings in me, right? Anger or whatever. They may be triggering this in other adults too. So you have to be aware about that. You have to be able to feed that back to the kid. And then also at some point, when there's enough of a therapeutic allowance, ask the kid, what are you trying to accomplish? Are you trying to make me angry? Because you're really good at that, okay? What is that about? And you'd be amazed at how young people can make sense out of it. The really young child may not be able to make sense out of it. You have to give them language to understand what's going on. Does that make sense? Okay, but countertransference is a big one. Okay, especially if you there's a type of countertransference. I think it's called a concordant one, and it's when a therapist identifies with the pain of the patient. That's one of the most difficult ones because that's what triggers the rescue fantasy.
As a psychologist, how do you help these victims cope?
Judy Herman's approach is probably the most effective. Judy Herman's trauma treatment comes in 3 stages. The first and foremost is something that we call safety and stability. That with most of these kids, we make sure that they're going to school, that they're not acting out, that they're safe, that they're getting rest, that they're eating. That could take years. Only when you have that do you then go to what we call recovery. That's when you start to look at a lot of the issues, the trauma memories and such, and then we do reconnection. So we're talking about a three sort of stage issue or treatment. Judy Herman saw it as linear. I actually see it as bidirectional, and so do people like Daniel Brown, who's a therapist around this area who does a lot of work with trauma. That when, after safety and stability, once you start doing recovery work, some people get triggered, so you may have to go back to an earlier stage. The one part that I think is missing, this is sort of the clinical, this is my sort of contribution to this, the clinical work around trauma treatment of children, is that I believe there's a pre-safety and stability called triage. Think about it this way, if somebody comes in and you're working in an emergency room and somebody's like bleeding, what do? You stop the bleeding. Right? A lot of the kids that I see coming in are dissociating. They're not even in their room. So a lot of the times, what I'll do is we'll use general language to acknowledge something happened to them, something terrible, and then I'll do visual work to help them contain it. Okay? Otherwise, you're not even going to get to stage one. You've got a kid who, first of all, think about traditional therapies. If one of the first steps is establish trust, let's go. So you can't establish trust. How the heck are you going to get a kid to get safety and stability to even listen to what you have to say? Okay, so a lot of triage work, sort of pre-therapy therapy has to happen first. You have to, build a connection with a kid who's afraid of adults who might have hurt them. So it's quite a handful. Okay? But though that's typically the work. And here's the thing: it's a treatable condition. Will the kids ever, get back on track? I like to think so, but the one thing that I've learned is that you cannot make scar tissue back to normal tissue. Does that make sense? So the kids are always going to have some residue of the effects of trauma on them. But I'm a big believer in awareness. At least if you know yourself and you know what happened, and you can explain why you're so quirky to people, if you trust them. But yeah, the kids always have something.
Could you validate that there are indeed apparent differences in how children versus young adults regarding their recovery?
I think that's a difficult one because it really comes down to the individual's resources, resiliency. I've seen younger kids be able to bounce back. I've seen older kids have difficulty bouncing back. But typically, the younger the child was at the age of the trauma, you just have a wealth of defenses that you have to get through. Probably the most important one is establishing therapeutic awareness. There are kids, and this sort of goes back to a question you asked about countertransference also, is you hear stories when the living ones start to tell you about the things that they experience. It can break your heart. Okay, so I'm not sure that you can make a clear-cut prediction about whether a child is younger or older, how they respond to therapeutic intervention. I'll tell you this: it's really important to intervene in some way. The reason is that there seems to be a real strong connection between a child who was assaulted, abused, no intervention, identification with the aggressor, and the likelihood of that child, becoming, a perpetrator in or herself. That's turning the passive into active position. So that's sort of the outcome of that. Abusive adults, almost always, probably abuse as children. Does that take them? Does that make them less accountable? No, absolutely not. But do folks who are abused deserve help? Yes. But for me, when a kid comes in, whether they're younger or older, or whether they're grown-ups who abuses children, right? I tend to think they can all be helped. Okay? But let me tell you, treatment is not fun and games. It's a lot of pain. There's a saying about how the sword cuts on the way in, the sword cuts on the way out. Okay? And it's essentially dealing with a festering wound that the child has had for a long time. They don't want anybody to touch their boo-boo. Right? And the longer they've been holding it, the chances of the greater the damage. Okay? But it's a treatable condition. Okay? Did that answer your question? Okay.
So we would like to thank Dr. Shim for accepting this interview today. You've given us insight into how pressing of an issue this is. Hopefully this will give us a head start on our project. We've learned a lot and hope that you all have also gained some insights too. Thank you.